Good evening, everybody, and welcome to tonight's webinar. The webinar tonight is on invasive group A streptococcus, an update and overview. My name's Michaela. I'm from Northwest Melbourne PHN, and together with my colleagues from Eastern Melbourne PHN and the Northeast Melbourne Public Health Unit, we'd like to welcome you to this webinar. I'll just let you know at the very beginning that we will be recording this session. This session will be recorded. And I will just share my slides. There we go. Hope you can all see those. The Northwest Melbourne PHN, Eastern Melbourne PHN and the Northeast Public Health Unit would like to acknowledge the traditional custodians on the land on which our work takes place. For me in Northwestern Melbourne, that's the Wurundjeri Woiwurrung people, the Boon Wurrung people and the Wathaurong people. And I'd like to pay respects to elders past, present and emerging, as well as to any Aboriginal or Torres Strait Islander people in the session with us this evening. Just very quickly, some housekeeping for our Zoom webinar session. So all attendees, you'll notice that you are muted. Please don't, you shouldn't be able to unmute as part of the session, but if you have questions, please put those into the Q&A box only, and we'll have a question and answer session at the end of the presentations. And as I said, this session is being recorded, so we'll be asking all those questions anonymously to protect people's privacy. I'd now like to welcome our two presenters. So Dr. Rachel Cowan is an infectious diseases physician based at Northern Health, who's one of the clinical leads at Northeast Melbourne Public Health Unit. And in addition to this role, she's also the head of infectious diseases at Ballarat Health Services. And we also have Dr. Scott Parsons, who's a GP with special interests in paediatrics, who currently works in the emergency department at the Royal Children's Hospital and a private general practice. Scott is also a clinical editor for Melbourne Health Pathways, focusing primarily on paediatric pathways. This is the agenda for our session this evening. So Rachel will be providing an update and overview of invasive group A streptococcus. Scott will then be presenting on Health Pathways Melbourne, how to pick the sick kid. And I would like to hand over to our first speaker for this evening, Dr. Rachel Cowan. Thank you.
Great, thanks very much, Michaela, and thank you very much to everybody for the opportunity to present today. It's a great opportunity to present on such an important disease, and certainly something that is creating a great deal of interest at the moment. I'm going to attempt to try and share my slides at the moment, and hopefully I can get this done successfully. All right, is that okay there, Michaela?
Yes, we can see those.
Fantastic, thank you. And thank you for the acknowledgement of country, and I would also like to pay my respects as well. So I just thought I'd introduce NEPHU, which is the Northeastern Public Health Unit, and just as a bit of an overview, it's part of the COVID response that initially happened in terms of the Department of Health realising that we needed sort of more localised response to COVID right at the beginning, and that we ended up dividing into 9 public health units across metropolitan and regional Victoria. And for NEPHU itself, our message is really simple. We want to develop an active, connected, safe community for everyone, healthy places, healthy people, and a healthier tomorrow. Interestingly, we have quite a fascinating setup in that it's centralised at Austin Health, but we also have Eastern Health and Northern Health as well as separate sites, and we have teams at each of those sites, because our demographic is actually really quite interesting. We have 12 LGAs, 2 PHNs, lots of community services, and 1.85 million people that we're actually servicing as the public health unit, which is about 28% of the Victorian population. And the demographics across those regions are really, really different, from going from sort of Eastern Health to the multicultural area at the Northern where I am. So it was really important to have teams at separate areas. And so initially, as I said before, we were actually set up with the focus on COVID, but now we're kind of moving through to that health promotion, prevention and protection activity. So it's development of processes around managing the 85 communicable diseases that we actually have. And we're actually in the process of transitioning those diseases for our care over sort of this year. We're also involved in contact tracing and management, both in the community for communicable diseases and also in residential aged care facilities, disability and SRSs as well. We are looking to continue to develop our public health information and education in the community, looking at preventative health strategies as well, at promoting healthy behaviours, etc., and also coordinating vaccination processes for COVID-19 and also mpox. So if we're looking at Group A streps, so Group A strep is streptococcus pyogenes. It causes a broad array of infections, and a lot of the stuff that you guys see out there is very much the non-invasive, the sort of traditional strep throat, pharyngitis, tonsillitis, skin infections like cellulitis or impetigo, scarlet fever and puerperal fever associated with pregnancy. But these manifestations, although majority of the time are very easily managed with antibiotics, they can actually lead to quite invasive disease. Invasive disease, which we'll go on to talking at length about. And then we've also got those post-streptococcal immunological sequelae, so the acute rheumatic fevers and the acute glomerulonephritis as well, which I won't be touching on today. So what is invasive Group A strep, or iGAS? It's basically Group A streptococcus when it's found in a normally sterile site. It includes necrotizing soft tissue infections, bacterial septicemia, pregnancy-associated infections, toxic shock syndrome, which we will be touching, so I'll touch on all of those diseases, pneumonia, empyema, retropharyngeal abscesses. It can lead to osteomyelitis and septic arthritis, usually in the setting of someone having hematogenous spread to those areas, and also meningitis. So why are we worried and why are we talking about it right now? So we've seen quite a significant increase in the global incidence of the disease, and you know, at least a doubling of the usual incidence. It's been reported in a multiple number of European countries and also in the US as well, and particularly associated with the winters in that time. And as a result of that, it's also been associated with an increased number of deaths associated too. What we are seeing is that it's predominantly affecting greater than 50-year-olds, and realistically speaking, those greater than 65, so the elderly population. And there's quite a significant amount of children under 10 years and under, and especially under 1, that we're actually seeing quite a significant increase in the incidence of the disease. So this, interestingly, has actually coincided with an increase in RSV and influenza circulation as well, and also has been or noted to be associated with an increase in the incidence of scarlet fever consultations as well. Yep. Locally, what we do know about iGAS is that there traditionally has been a disproportionate impact of the disease in the Aboriginal and Torres Strait Islander population, and their notifications account for 74% of notifications. However, in Victoria, what we are noticing over the last sort of 18 months is that we're actually getting quite a significant increase in the notifications of iGAS. So in Australia, about 184 notifications over the year of 2022. And as you can see in the graph on the right, which is broken down by month, there is quite a significant increase in the number of notifications in a really short period of time. And we're sort of half at notifications in a 2-month period. In Victoria, increasing numbers, and I'm sure you've probably seen them, have led to Safer Care Victoria and the department, the Deputy Chief Health Officer providing health alerts regarding Group A streptococcus and being mindful to watch out for it as well. they've seen a number of severely unwell children, including paediatric ICU admissions and some deaths associated with it. And in spite of a heightened awareness that people, of the clinicians and people in the community being aware of the disease, it is reducing the time to being treated. However, we are still getting quite a significant number of cases that are being detected. So why do we have this increased incidence and severity? We've seen increases in both non-invasive and invasive disease, and I'm sure you've probably seen all of that in there as in your own practices, and certainly in the hospitals, we are most definitely seeing an increase in the incidence and severity of the diseases. We've also seen it linked to highly intense respiratory syncytial virus and influenza seasons as well. So we're getting sort of a double-edged sword in terms of we're getting secondary infections, bacterial infections post-viral infections, and also co-infection as well. So you're getting both diseases at the same time, and that does increase the rate of invasive, or the risk of invasive disease, because we are getting localized inflammation, and that provides a method for the bacteria to actually translocate. This is some data on children in Spain, and what we can see, it's looking at sort of COVID and COVID lockdown and the effect of lockdown discontinuing, and then the loss of mandatory of masks. And what we can see in the blue is actually showing RSV incidence as well. And we can see, especially over 2022, as I was saying before, that significant increase associated with RSV infections. The other thing is that in the last couple of years, due to lockdown and due to people just not isolating and just not being out in the community as much, we're actually seeing an increase in pathogens, and group A strep being one of those pathogens suffered by social isolation. We're not getting that background immunity and that those sort of more grumbling infections. The WHO have been looking at some isolates and don't think that there's been any more invasive strains being that are actually emerging, but it's hard to say, and they're still actively monitoring this. So group A streptococcus, which is basically aerobic gram-positive coccus in the picture in chains. They colonize the skin, nasopharynx, and anogenital tract. We know that there's transmission via large respiratory droplets and through direct contact with infected people and carriers. And it's communicable, and its communicability is actually, or transmissibility, is actually dependent on whether you've got antibiotics or not. So it's a little bit interesting in that perspective, in that if we've got someone on appropriate antibiotic therapy, we know that it's communicable for about 24, 48 hours. But if they're untreated, there is a potential for them to pass on the disease sort of 10 to 21 days down the track. It's rarely transmitted by fomites and indirect contact through objects. The incubation period is usually 1 to 4 days, so it's pretty quick. There are a number of virulence factors, and it's quite, I'm not going to labour a lot of the points and the virulence factors. As you can see here, there's an enormous number of factors that come into the aggressiveness of group A strep. We also see the same with staphylococcus as well. But the one that's probably the key thing as far as invasive group A strep is really around that pyrogenic exotoxins that are actually released. These antigens and superantigens are actually activate the immune system. They bypass those regulatory immune system things that we have in the immune system that stop us from becoming, immediately sick, and that we can normally control infections. And as a result, we're actually getting a release of an enormous number of inflammatory cytokines, which is the response that we see, and the rapid progression of disease that we see with group A strep. So who's at risk? There's an enormous number of people at risk. having said that, the overall risk of invasive group A strep is actually pretty low. Although it's increasing, it's in the realm of about sort of 0.6 to 1 per 100,000 persons. But that, as I said before, that's sort of getting up to 2 or 3 per 100,000 persons at the moment, which is why we're noting it. As I said before, people that are older than 65 or younger than 5, Aboriginal and Torres Strait Islander people that have got a viral infection, so co-infections, but also the other one of note is actually chickenpox or varicella infection, actually predispose people for development of iGAS. Anyone with minor trauma, so going from manky outside to clean inside, stairway to heaven, as it were, getting in there. So, and also that sort of bruising or muscle strain, bugs seem to have this love of getting in and getting to places that are inflamed. Insects, bites, burns, recent surgical procedures, household contacts with someone who's had iGAS in the past 30 days, and we will go into that and management around that too. People who inject drugs, people who are immunocompromised as well, obviously, high-dose steroids, chemotherapy, diabetics, pregnant and postpartum women, and also those that are homeless, living in overcrowded housing or lack of hot water. It's really about getting rid of the bug and not sharing it between the individuals. So paediatric and iGAS, I think I'm not going to labour these kind of points because I know that these will be discussed a little bit later as well. The issue with iGAS is that children are non-specific, can be non-specifically ill, and especially initially, and it may be very difficult to initially make that sort of work out whether it's a viral infection or it's going to be group A strep, and it can be very difficult to tell. And I know that we're going to get some tips later. But those with persistence of signs and symptoms, presence of multiple signs and symptoms, or extreme nature or progression of those, in particular that cold mottled look, the pain, inability to walk, the lethargic individual, so the floppy child is always one that makes me catch my breath when I actually see that as well, and oliguria, obviously, but I won't go on to these. So it's really important to take a careful history and record a timeline for the illness, full assessment of severity, including cardiovascular assessment. And it's just really about being alert to the child or adolescent who's more unwell than you would expect with a viral illness, or has had a viral illness and then becomes unwell, is to have that index of suspicion. Safer Care Victoria, my colleague that helped put the slides together, who works with Safer Care Victoria, one of the things when they've been reviewing the cases is that the initial assessment by the general practitioner has not been unreasonable about this as being a simple viral infection. And then it's the acute deterioration after that you just couldn't have picked in the GP practice. So it's about planning about what to do after you send your person home, your parents home. If you're assessing someone and they're clinically very unwell, or you have a really high index of suspicion, early resuscitation is really the key, and early antibiotics and surgical management if needed. So you may actually need to transfer them through to a tertiary centre, and you can contact Piper for that. In any child with persistent multiple or severe signs, get some blood cultures, get some throat swabs or some wound swabs if there are any wounds, and commence antibiotics pretty much straight away. And especially if there's been a preceding viral infection that you think are suspicious, those who have had close contact with someone that's previously had iGAS or has scarlet fever or pharyngitis or tonsillitis, then just start the antibiotics. What do we need to tell parents? And I think that's the important thing. It's really difficult not to just start antibiotics in an unwell child just in case. The problem is that the just in case antibiotics are associated with changes in microbiome, development of resistance, allergy reaction to antibiotics. I could go on all, ad nauseum, and the actual incidence doesn't actually warrant that. Do trust your clinical acumen around this, and around whether you think this person or this child or adolescent need antibiotics. But hyper awareness really is the key, and so it's a matter of informing the families that, if anybody's unwell, then represent back to healthcare, and if they really do have that acute deterioration where they've got sort of gone from relatively, grisly but okay to floppy child, then that's when you really need to get the child or the adolescent to hospital as quick as you can, calling 000 with that rapid deterioration as well. So it's just having it in the back of your mind, because sometimes it's like, oh, we'll just see how it goes, or we'll just see how they are in the morning. It's really about getting people to hospital quickly. And even if that means that they get assessed in the emergency department and they're sent home because they really aren't clinically that unwell, that's actually okay. We don't want everybody turning up to the emergency department, obviously, and they started with you making a good decision in the beginning. But it's just having that index of suspicion that if they do deteriorate, that they really should present to hospital. Adult iGAS, as I said before, is quite a significant range of presentations, and certainly the cases that I presented before would be indicative of how quickly things can develop. Cellulitis and pharyngitis traditionally are not considered to be that invasive group A strep disease. When we're talking about necrotizing skin infections, we're talking any layer of the skin. It's epidermis right through to the fascia and the muscle. And most commonly, we're looking at extremities. It's more often than not the lower versus upper, but I've seen some spectacularly nasty infections in the upper limb. Risk factors include diabetes and peripheral vascular disease. And it's usually an acute presentation and a very rapid progression that we see. And the key really is the pain out of keeping with the appearance. We all have seen cellulitis, and it's that red hot angry leg. And I find it fascinating, that red hot angry leg, because you can see it, and it's so easy. It's like that's the problem. And often they'll be constitutionally unwell before that red hot angry leg actually appears. With this, it's when you examine someone with potential necrotizing soft tissue infection, it's almost got more of a dusky appearance. It's not that really bright red. It's that dusky, like you would see after a couple of days of treatment, or almost with antibiotics. That sort of dusky appearance can be quite mottled, and it's really, you go to touch it and the patient goes to punch you in the head because they are in so much pain. And it's really that pain out of keeping with the appearance which just triggers things for me. And they often are really clinically unwell with it, the tachypnea, the tachycardia, the hypotension. And in those patients, you actually need urgent surgical management, and they do need transfer through to hospital. And I think it does actually warrant a call if you really are that concerned about a patient, that you actually call the ED admitting officer to warn them and let them know that this person's coming through to triage, so we can get people in as soon as possible. When we're going on to pregnancy-associated infections, so group A strep or postpartum, it's a really important cause of maternal and infant mortality. Usually arises about 48 to 72 hours after delivery, and about 20% of cases can occur prior to rupture of membranes, and it can occur after discharge post-delivery. So this is where the young mother may actually present to you. And features include fever, that abdominal pain, uterine tenderness following childbirth, which is really out of keeping with what you would normally see post-delivery. Bacteremia and septicemia. Usually it's associated with an infection at primary site, but in about 30% of cases you don't actually get a source. Most common sources, as I said before, cellulitis, burns, wounds, pharyngitis, tonsillitis, and pneumonia as well. And really the red flags for transfer through to hospital in terms of that septic picture that I'm talking about before. The sort of the hard and fast numbers are really respiratory rate greater than 22, heart rate greater than 120 beats per minute. Everybody associated sepsis with fever. That is actually not true. Only 70% of people with sepsis will actually have a fever. About 13-15% will actually be hypothermic. It's really the respiratory rate and the heart rate that are the two key features. You become acidotic when you're septic. The best way to blow off the acid is to blow off your CO2. That's why your respiratory rate goes up. So it's really respiratory rate and heart rate. Systolic blood pressure less than 100, being mindful of what their usual BP is, because if they've got poor ejection fraction, they won't have a great BP. Temperature, as I said before, rigors, so that whole body, teeth chattering, earth moving shakes they can't stop. Altered conscious states are much like the drowsy child. Clinical syndrome with a potential source, and also that rapid deterioration in that clinical state. Toxic shock syndrome, it is a complication of iGAS, and that is when we start getting the shock and the multi-organ failure, and it's usually it is related to that capillary leak and release of inflammatory cytokines. We see it about 1/3 of iGAS cases and about 50% of necrotizing fasciitis, which was one of the cases before. Those red flags that I previously mentioned. Sometimes people can present with that respiratory sort of influenza syndrome, the fevers, the chills, the myalgias, they're vomiting, they've got some diarrhea. And also, without the soft tissue findings, they can present like a pneumonia or a myocardial infarction or something like that, or abdominal sepsis. It's with significant abdominal pain, so it can be a little bit confusing. And a lot of them will have that end organ dysfunction, so the renal failure, the liver failure, the acute respiratory distress syndrome, and also the disseminated intravascular coagulation. Other manifestations, pneumonia, it's uncommon, but it can occur. Usually it is associated with a viral infection prodrome beforehand, often multilobular diffuse disease, and pleural effusions in about 80% of cases will actually be empyemas. So you don't just get that parapneumonic effusion that will settle down when someone gets over the pneumonia. Most often it'll actually be an empyema and be infected and need to be surgically managed. And obviously the peritonsillar abscess. So looking at treatment, obviously requiring hospital admission, rapid fluid resuscitation and vasopressor support is often required. When we're talking about intravenous antibiotics, penicillin is the drug of choice. So in any of those Lancefield groups, so the Group A, the Group B, the Group C, the Group G streps that we see, penicillin, exquisitely sensitive. Interestingly, we really haven't developed resistance as yet around penicillin, so I love penicillin. Cefazolin if there's an immediate non-severe or delayed non-severe hypersensitivity. Vancomycin, the thing being that we really need to think about those, and in those that are actually septic, we do need to add in clindamycin. Clindamycin is a really interesting drug, hangs around for a long period of time, but the problem in these people with iGAS is the toxin production, and clindamycin works at the site of toxin production, it works at the ribosomal RNA, and it stops toxin production. So it's a really important thing. And suppression of, it suppresses the penicillin binding proteins and actually hangs around for a longer time than the beta-lactams post-dose. Surgical debridement is critical and close monitoring is critical. Preventative measures, there's no current vaccines. As far as the case is concerned, obviously we need to be treating them as we need to. Infected children should be excluded from school until they've had 24 hours of antibiotics. Generally speaking, if they've iGAS, they're going to be away for a good period of time, and good hand hygiene practices are useful. Contacts are really the interesting thing as well. So if you've got a contact who is symptomatic, then I would consider that they also have group A strep and should treat accordingly. There is an increased risk of secondary cases in iGAS of household contacts or significant contacts. So those with intimate kissing, sharing a bed, intimate activity of an index case, much like you would think of in the setting of meningococcal disease as well. The rate of secondary infection is, quite significantly higher than the general population, still rare. It's about educating the household contacts to be mindful, to be aware that they could develop a disease. But interestingly, the role of antibiotic prophylaxis for household contacts isn't established, but in those that have had an invasive group A strep, but those that have been floridly sick, that sort of ICU admission, group A strep toxic shock, we would actually, us as infectious diseases physician, would actually treat. Interestingly, we've had a recent survey around the infectious diseases physician, and half of them will and half of them won't. But I think at the moment, given the incidence, it's not an unreasonable thing to be considering giving prophylactic antibiotics. And it's really about prevention of colonisation with a virulent strain, so they don't actually then go on to develop a secondary infection. Particularly warranted in immunosuppressed, the elderly, the pregnant, recent surgery, and those with open wounds, and also those that have been exposed to iGAS in the preceding 30 days. Treatment would be with penicillin, so phenoxymethylpenicillin or amoxicillin usually would be appropriate. Children also small doses, as you can see there. And control of the environment, just standard control procedures. As far as notification to the Department of Health, it's really the laboratories that are required to routinely notify us within a 5-day period. Medical practitioners are not required to notify of iGAS. I think basically the take-home messages that I'm trying to say today, so just drawing my part to an end. Currently, unusually high rates of iGAS, and there was the initial thought that this would be a rapid increase and decrease, but it's really hanging around, so we really need to be getting the message out there. If you're suspicious for it, then test for it, throat swabs, wound swabs, treat the infection empirically if you need, if you really do have a high index of suspicion. As I've been saying, early recognition and prompt initiation of treatment is important. In the high index of suspicion and maintaining a low threshold for prompt referral to a tertiary centre, and educating your patient and your family about presentation if they do acutely deteriorate. Here are some iGAS references that we can send through. I just really like to acknowledge Philippa, Claire Gordon, Sophie Trelevan, and Hibak Ahmed as part of the NEPHU team, who have very helpfully put a lot of these slides together for me because I just got back from holidays today. So thank you for the opportunity for chats, and I will hand over and we'll catch up with you later. I'll stop sharing.
Thanks so much, Rachel. I'll now hand over to Dr. Scott Parsons.
Thank you, Rachel. Very pertinent at the moment. Wanted to, I'll just share my screen. My talk's very different from Rachel, which is great because I didn't really want to sort of try and involve any of the statistics and current situation in Victoria because I knew that that was going to be covered. But what I was going to do is talk a little bit about how we pick the sick kids in emergency departments and how you can tell which child you need to say, yeah, I think we need to do something, or we need to watch for a little while, or we can safely sort of send home and reassure. And in kids, streptococcus is common in the throat in those kids over the age of 4 or 5, strep pharyngitis. And often those kids, sometimes they don't need treatment unless they're part of a high-risk group. The consensus about treating them is difficult because over the last few years we haven't been, but obviously with what's happened in the last last few months, there is some talk about going back to treating kids where we suspect strep pharyngitis Under the age of 5, strep is more likely to be, doesn't appear to be a factor in pharyngitis, and we often spend most of the time stopping antibiotics in kids under the age of 5 who've got sore throats and coughs and colds, because they really don't have, there's not much evidence for strep pharyngitis in this age group. However, there is evidence for invasive strep disease that doesn't come from the throat, and this is a difficult scenario. So how do we pick the sick kid? Well, what is a sick kid? What are they going to have? Well, they're going to have an invasive bacterial infection, and the invasive bacterial infections we always worry about in the emergency department. The most common by far is urine infection, and they can be mild. They're generally, if they've got a bladder infection, they're not going to be particularly sick. We're just going to have a UTI, but some of the kids will look pretty sick, and they'll have urosepsis and need to be admitted. And we've got other invasive bacterial diseases, includes the bones and joints. We've got pneumonia, meningitis, and of course sepsis. Now, sepsis is the one that we really get scared of because they're very hard to pick. Other illnesses, something else, Kawasaki, PMS-TS, following the Omicron COVID strain. It's more common in that strain. It seems to have lessened a lot over after the initial sort of cases that we saw a year or so ago. Other kids that other conditions that we're looking at is oncological conditions such as leukemia, and obviously metabolic conditions. They're nearly the first presentation for type 1 diabetes. So in the health pathways section, which hopefully most of you have had a look at, these are the 4 pages where gas is really involved. Normal paediatric observations is probably the most important page to have an access to and print off and have it sitting beside you in the clinic. But there's one observation that I'm going to talk about, which is probably the most important one of all. The other pages we use in health pathways: fever in children, rash in the underwell child, on sore throat in children, which is very much aligned with the sore throat in children clinical practice guidelines from the children's. So in the ED, this is what we see. We see 1 to 2%. It's obviously sick. They'll come in, they'll be categorized as 1 or 2, and they'll quickly be seen, assessed, and managed. They're the obvious ones that will come in by ambulance, or clearly they're very unwell. Then below that, we've got the 90% coming with fevers, coughs, colds, runny noses, parental concern about temperatures, intake, the nature of a cough, and they'll be categorized as 4s and 5s. And in the middle, we've got the 10% where we're not really, they don't look particularly bad, but they're certainly not fulfilling the criteria where we're happy to send them home. So those kids will often get a period of observation in either in the ED for a little while, or even in our short stay unit. And if their observations settle down, then often they'll be discharged. But often they can cross very quickly from the orange to the grey to the red, and that's where we see sepsis. So Joel was 4 when he came in, and he had a very quick illness. Basically woke up and his mum reported that he just didn't really want to have any breakfast, and he didn't seem very happy to do much, so she took him to the park. He didn't get out of the pram at all, but he vomited 3 times, and mum just didn't feel he looked very well at all. He had no past history of any significant illnesses, and it's the first time he'd been to the ED. The triage nurse didn't feel that the history was particularly concerning and put him as a Cat 4. He sat in the waiting room for an hour. He was febrile. He didn't really want to walk. Sorry, he's a category 5, this one. He didn't really want to walk. At the 1 hour mark, he was seen. He had limited conversation. He just appeared to be sleepy. He complained of a sore shoulder. He was sitting in the pram, did not want to walk. He was febrile, and he was also grunting, and he was tachycardic at 180. And that's a 4-year-old. Half an hour later, it was clear he wasn't well, and he ended up having a lactate, which showed that he was at the risk of sepsis. And a few hours and short time later, he was in paediatric intensive care requiring inotropes and penicillin. This is how fast the sepsis hit. It's in front of your eyes. These kids will crash. And 4 hours earlier, if the GP had seen him for a couple of vomits, there probably wouldn't have been any features or in an ED. And this is the problem. If we'd seen this kid, he could easily have been sent home, and then he'll come back, and then they end up being a disaster for everyone, particularly everyone that were involved in the care will suffer greatly from missing this kind of child, but they're very hard to pick up. But there's one clue that I'll go through in a second. This is the kind of things that we look at: febrile and look sick, unable to mobilise, refusing or unable to walk, parental concern escalating, getting worse, unexplained limb pain, and the main one here is progressive persistent tachycardia. Grunting is also another factor that's not explained by respiratory symptoms. Now, a lot of the first four, the febrile, look sick, this is very difficult because if you walk around the waiting room, a lot of the kids look sick. A lot of them won't really want to walk. A lot of them are miserable and irritable. And often parents are very concerned about all sorts of things. But the feature is that this child's deteriorating. Unexplained limb pain is definitely a red flag. And this kid had shoulder pain, and he had the progressive persistent tachycardia. A lot of the kids who fit in the mild categories, we will do a serial observation, give them some Nurofen, some Panadol, an Icypol, and then we'll watch them quite closely and see what their OBS are doing. And if there's a pattern of change in the variables, this is very important. If they're dramatically improving, then we know we're not going to be having any issues regarding sepsis. But if things are getting worse, these kids will quickly need to escalate. Interestingly, the child I talked about before, he had a full blood count of CRP rate taken pretty early, and that was completely normal. And then the one blood test 40 minutes later looked awful. So these kids crash very quickly. So we're going to talk about heart rate and what affects heart rate. Well, we've got stress, we've got crying, we've got fever, we've got other factors. Sick variables include hydration, systemic infection, and anemia, and respiratory conditions. Assessing tachycardia, we need to know some normals. And on the children's website and on Health Pathways, we've got the acceptable ranges for physiological variables. Now, these are all the top 5% of the percentiles for normal. So anything outside that, we start to look at very closely. Now, that looks quite complicated, all these variables, but if you summarize it, it's only two features: under 2 years, greater than 180, over 2 years, greater than 160. If I see a child and I've got a pulse of 180 under 2 years, over 2 years, 160, and I haven't got a good reason why, I'll start looking very closely at this kid and really taking some notice, and I'll certainly be watching them far more closely. And this is what happened with this boy that came in to see us. He had a heart rate of 180, and we didn't, and it wasn't explained by the fever. Right, so we're flicking over to art. So BG, Staying Alive, is the classic song for our how you measure a heart rate, because measuring a heart rate in the GP can be quite difficult. Measuring a heart rate in a fractious toddler or an infant is actually quite difficult. Trying to put a SATS monitor on to get an accurate heart rate, they'll get distressed and upset, and you won't get an accurate heart rate. We don't have the luxury of monitoring devices, electrical monitoring devices. So we've got the old-fashioned listening to the heart and counting, and that can be quite laborious. So here's a hack. Pick some songs that have the beats per minute to a particular heart rates. And find a song that you can easily reproduce in your head, and then you can Google their beats per minute. And these are the ones, these are some examples. So these list of songs actually shows my age, which is a bit embarrassing, but some of these songs will certainly, some of you will know. For instance, Blondie, One Way or Another, is 160. There's an old song called Turning Japanese, many of you will not have heard of. That's 180, but there's plenty of songs with a beats per minute of 180 that you might be able to come up with. So come up with your own set of songs. Now, if you get a child who you go, yeah, this is not sounding too good, I want to get an accurate heart rate. There is another hack here. Now, the hack is an app, and if you QR code that, you'll get straight to that application. Now, this is an application on Android and iPhone. And all that happens then, you open the app, and you can tap on the phone exactly what the heart rate is. So listen with your stethoscope, tap the phone, and you'll get a very accurate heart rate. And the beauty of this one is it works on the watch. So those of you who've got Apple Watches, and there's an Apple Watch, and this is an infant teddy bear, and you can see his heart rate is 164. If you look down on the left-hand side, so you tap the watch with your finger while listening with your stethoscope, and this is what we do a lot of in the ED to assess the heart rate of any infant who's come in with any particular condition where we feel that this is essential, and they haven't had a set of obs before. So this is a hack I wanted to show you just to make you more confident. So if a child's got a heart rate of 120, 130 with a fever, looks a bit ratty, and you can be rest assured that it's unlikely that this child's going to deteriorate. But if it's over those lines, I want to watch that kid a little bit more closely. We're just about at time. If you want a resource on sepsis that summarizes everything, there's a terrific website for pediatrics. This is a website called Don't Forget the Bubbles. And Bubbles is a fantastic sort of safe way of distracting children and making them feel comfortable. And so they've named the website Don't Forget the Bubbles. It's got a terrific article on how to spot sepsis and goes through the positive and negative sort of symptoms and signs. Finally, while I'm getting the opportunity, I want you to show throw this in as well, that in Health Pathways, we've got infant guidelines. We have developed an infant guideline on how to examine the infant at 6 weeks. This is a bit off topic, but I wanted to point out that this answers all those little questions that you get from parents about how examination issues. And so this is in the infant health pathway. So I wanted to throw that in there because this pathway is very useful. And a lot of the paediatricians have been telling me that they're getting a lot of inappropriate referrals to their general medicine group on little things like, for instance, presumed premature closure of the anterior fontanelle. This has got all the guidelines on there. So if you're looking at infant pathways, have a look at this infant pathway on infant examination, and it's a very good resource. So that was just something that some of the paediatricians asked me to talk on as well, to mention that if you can have a look at this. I think that's all. I think we're just in long in time. So thanks, Michaela.
Thanks, Scott. I'll let you stop sharing your screen.
Yeah.
Wonderful, thank you. Now we do have a few questions in the chat. If anyone's got any additional questions that they have thought of, please feel free to pop them into that Q&A box down the bottom of your screen. But I will just read out the questions, and apologies for there's a couple in here that I've seen that is talking about some specific antibiotics, and I'm hopefully one of our clinical presenters will understand what all those bits and pieces mean. So we've got a question, first of all, around the signs and symptoms. The question is, would you mind clarifying what signs we should look for to differentiate viral pharyngitis and tonsillitis from group A strep? And this is someone who works in a respiratory clinic.
Shall I take it for adults? You take it for kids, Scott?
Yeah, sounds good.
Yeah, only because I don't do children, so I think it'd be very useful to get, yes. As far as sort of making that differentiation, it's really, it can be a little bit difficult. A majority of cases, especially in the adult population, of sore throats and stuff like that would act, and viral pharyngitis will be viral. The things that will lead you to think more that it's viral is associated, like coryzal symptoms, so runny nose, runny eyes, conjunctivitis, kind of sore, that we along with that sore throat, I think would be sort of a cough, sort of, you know, hoarse voice, those kind of viral illnesses that you would actually expect, like those, that sort of constellation of coryzal symptoms. As far as sort of having those group A strep, it's sort of, they are clinically tend to be more, they have more of an exudate on their tonsils. They've got sort of tender cervical lymph nodes. They, you know, are tachycardic, tachypneic, that kind of stuff. They're sort of febrile. If they've got sort of a rash or something like that, that they would probably be more you would, especially, I'm assuming Scott's going to talk about the scarlet fever kind of rash associated with it as well. So they don't tend to have those coryzal associated symptoms, so, you know, in adults.
So that's a very good question, because it's a when do you use antibiotics in kids? And so there's features of gas that I feel that we would consider is it's an older child, older than the age of 4 or 5. They've got a history of fever, no coryzal features, unilateral adenopathy. So if they got bilateral, that's more likely to be viral, but one-sided unilateral anterior cervical adenopathy, red inflamed palate pharynx with exudate, unwell appearing, and no palpable spleen or anything else that would suggest EBV. One of the biggest problems is EBV is often thought to be is treated with antibiotics, and EBV will look similar in a lot of categories, but they'll have bilateral cervical adenopathy, they'll have coryzal features, and they'll often have a spleen. So I always go looking for a spleen in these kids when I'm not really sure. But if I don't have viral features, I've got quite a nasty looking throat, unilateral adenopathy, then I feel like strep would probably be right up there. And the other feature that sometimes people talk about is palatial petechiae or donut petechiae. You do see this with Coxsackie viral infection as well, but if I do see that in older kids, I think that is quite common with strep to have those donut petechiae, and then I would treat. I wouldn't bother with a swab because of the fact that so many kids are going to have a positive swab anyway. The scarlatiniform rash is usually will occur in the groin and the armpits. There's a rough sandpapery rash, and then it spreads to the abdomen. And some of these kids are not particularly sick or unwell. And although the clinical guidelines sort of say, look, we don't have to treat these kids if they're very well, it's something I think you'd feel pretty nervous about not treating because of particularly in this environment. And yeah, so I think that's the answer there. I think hopefully that's covered the difference between sort of viral and strep throat infections.
Thank you. There's a comment here, excuse me, from someone who says they try and use the RCH guidelines, and it says on their site that Group A strep is rare in under 4-year-olds. I guess, Scott, that kind of touches on what you were saying with the over and under 4. Should this guidance be adjusted?
It's not. It's Group A strep pharyngitis is rare in under 4-year-olds, but strep is certainly common on the skin and the anorectal area. We see strep quite commonly in the anal area, but we don't tend to see it we don't tend to see Group A strep affecting the throats like we do in the older kids. So that's why we tend to we don't like seeing infants being put on antibiotics for sore throats and things, because it's not going to be strep in that age group.
Thank you. We've got another question, and apologies for my the shorthand of different antibiotics here. During a mass shortage of phenoxy, can we give amoxicillin? ETG says it's reasonable, but then if that's not available, we've got azithromycin and cephalexin. Should we go, is it clindamycin then in that last resort case? Sorry if I miss any.
Yeah, no, I think that's probably the way I would go. I would definitely give amoxicillin before anything else if I couldn't get phenoxymethylpenicillin. If it's not available, then yes, you could go azithromycin or cephalexin. Both of those are reasonable options, and I think they're actually in the guidelines anyway. Last result, yep, absolutely clindamycin would be. If you're talking not just for throat or anything, if we're actually talking about leg as well, and quite rapidly progressive cellulitis, which you can see, or tracking of that, the erythema up the leg along the lymphatics and groin pain, then yeah, clindamycin is actually a reasonable option, because that suggests that there's toxin involvement if you're actually getting tracking of that cellulitis along the lymphatic pathway, or that really rapidly progressing cellulitis. You could potentially use it, but with strep pharyngitis, I think that's entirely appropriate.
Thank you. Another question here for you, Rachel. You said that streptococcus, said to test for streptococcus, but ETG still states most patients who are not at a high risk of acute rheumatic fever do not need antibiotics for streptococcal pharyngitis or tonsillitis. Are we testing people who we suspect have iGAS, who are hypertensive or hypertensive, sorry, or are you advocating more liberal testing and treating?
It's really interesting. These guidelines are currently getting reworked at the moment, so I'll be really interested to know what they're going to bring in, because I think they're going to have to put in the increased incidence in there potentially as well. It's yes, most of the people will, like, you know, viral sore throat, they will resolve in about 3 days, 3 to 5 days max. With a streptococcal infection, they will also do the same and settle down over 7 days. And most of the time you don't actually need to give antibiotics, but it's really about having that index of suspicion in those, in particular, those that are immunosuppressed, those that are elderly and 65 and quite comorbid, those that have been exposed to someone who has recently in the last 4 weeks had iGAS, because they're obviously being exposed to a more virulent strain of strep pyogenes. Basically that kind of immunosuppressed, or those that are actually more clinically unwell than the average person walking in, so they're tachycardic, that kind of stuff. I would probably suggest that you could treat.
I'd also like to add all the First Nations, Pacific Islanders, Maoris,
yes,
and Indigenous, because of their incidence of rheumatic fever is so much higher than Caucasians, and that's the main reason they really do suffer from strep in Pacific Islanders, and particularly have high incidence of rheumatic fever. Yeah.
And also, if you're considering in that exact population as well, if you're actually considering that they might have a staphylococcal infection or a Staph aureus infection, then most of the time it's non-multi-resistant MRSA, and clindamycin is really the way to, or Bactrim is really the way to go in that population of people, because they more often than not, especially up in the Northern Territory and Alice Springs, they won't. They've got non-multi-resistant MRSA. So not the hardcore MRSA, and they love to form boils and pus.
Thank you. Next question, would it be possible to hear the explanation for co-infection of group A strep following a viral infection?
Yep. So I was sort of talking more about sort of two scenarios. So one where, and we see it also with staph pneumonia as well, is that if you have a viral infection, you're causing localized inflammation, and so you can potentially get translocation of bacteria, and that would include group A strep as well, as far as sort of translocating across the throat and the epithelial cells, and also or you can actually get a co-infection where you'll get, RSV and group A strep at the same time. And it's not sort of one clinical where you get a viral infection, you kind of get better and then you get worse again. So you get that secondary bacterial infection. It's all kind of happening together because you do have that inflammatory process. I hope that makes more sense.
Next question is, what is the risk of iGAS to contacts of those with group A strep skin infections, such as impetigo?
Good question. I'm not sure of the exact number. Like I'd have to look up the exact reference. Obviously, the risk is generally thought to be more associated with throat rather than impetigo, but I can't answer that off the top of my head. Sorry. We just know that currently iGAS is at sort of at least double the rate. So the background rate is usually sort of, as I said, I think about 0.5 to 1 per 100,000, and we're seeing at least 2 to 3 at the moment. Scott, do you have anything?
I think if you've got someone who's susceptible to iGAS at home then you'd be more aggressive with your treatment of impetigo. And impetigo is transmitted by skin-to-skin transfer, and sharing of towels and that sort of thing. So the guidelines at the kids, if you see the parent guideline on impetigo, talks about washing all the towels in hot water and just doing a little bit of hygiene stuff to prevent that's why they're called school sores, because they tend to be very infectious, and so I don't think you'd be treating the family members with any antibiotics unless the child really was pretty infected. But yeah, and there were some high risk factors.
Another question. I had a patient who was improving with a sore throat, absence of coryzal symptoms, discussed antibiotics and decided to closely observe. By the time the swab came back for group A strep, the child was clinically better and improving. And the question is, should I have treated with antibiotics when the swab came back?
No. Unfortunately, look, Rachel, you probably know this. I think it's 30%. Is that the number of the carrier rate? Is this up to 30% in some?
It is. Yeah, I think it is about that as far as sort of carrier rate. So the thing being is that if they're clinically getting better by the time, if you've made the decision just to observe, which is entirely appropriate, I think if by the time you get the results back, they're clinically improving, as with anything, I wouldn't normally treat. I think it's one of those things that we're kind of making people hyper aware, and I've probably inflamed the intensity, but I think around concern around it. But I think it's just, for me, the key thing is being mindful to look out for it, because it is still rare. Be mindful, look out for it, and it's really about educating the family members that they need to be aware that if they do deteriorate quickly, that they do need to present to hospital and not just go, oh, I'll see how I am in the morning or something like that.
We have a question about should we prescribe penicillin for any infected scabies, in particular Aboriginal or Torres Strait Islander babies?
Scott. It's a baby thing.
Yeah, it's definitely infected. The scabies does get infected quite commonly, and I'll be using Keflex, not because more likely there'd be staphylococcus for infected scabies, but strep is certainly would be the number 2, and Keflex would be the antibiotic of choice in that particular age group.
But I think if they're in the sort of that more islander population or something like that, and they're not clinically improving on the Keflex, because they can still have sensitive staph as well, that you would make you'd review it sort of in 2 to 3 days. If they're not getting better, I'd swap over to something that was non-multi-resistant and make sure you get a swab.
There was just a follow-up question. If MRSA staph infected scabies, what's the best management for Aboriginal and Torres Strait Islander babies?
I'd be making sure you get the right dosage of antibiotics, because if the resistance may be overcome by having an appropriate dosage of for instance, in a UTI, we tend to not change if the child's a lot better after they've been on an antibiotic, which when the urine infection comes back as resistant to that organism and they're much better, then clearly that antibiotic actually works okay. So making sure you get the right dosage, and using the AMH or the Royal Children's guidelines on the dosage, because they're much better than the dosage you get in the MIMS. And that's another issue we're talking about, is the inappropriate dosage of antibiotics for this. But Bactrim would be my second choice. Does that be right, Rachel, from the point of view if you're feeling that we've got a skin infection?
I think so.
Resistance? Yeah.
Yeah. Bactrim or clindamycin tend to be the two that you would think of.
And last question, I've been swabbing some patients and really thought they'd be positive, but they were negative. And now I wonder if I'm actually taking reasonable swabs. Any advice on how many swells around the tonsils and uvula for effective swab?
Over to you, Rachel.
With sometimes it is sampling error. Sometimes it may just be that they've actually got a viral infection and we're not actually going to pick that up with the swab, and that's why your swab's actually negative. I think if they've got a good going sort of collection of pus or something that you can see and you swab it and it comes back negative, then it's probably being induced by a viral infection. I would think if you got a good going, I would expect it to be positive if you've done a good sample. As far as the number of times, I think it's just, I don't think that you're actually doing anything wrong at all. By the sounds of things, it sounds like you're doing a thorough swab, and it may just be that it's not group A strep.
Great, thank you. That's the end of all the questions that we have this evening. If any questions do come to you, we will be sharing all of these slides and resources in the post-session email. I'm just going to pop up my screen again. Oh. Sorry, I hope that's working. So there's a QR code on that screen for our feedback survey for the session tonight. We'd really appreciate your time filling that in. When we end the session, it will also automatically pop up. So we'd really like to thank you all for being part of today's session. It's been a pleasure to have you. And of course, we'd like to thank our presenters, Rachel and Scott, for their time this evening and for sharing the valuable information. As I said, there will be a follow-up email. We'll be sharing the resources that have been mentioned during the presentation this evening, as well as some additional resources from our presenters. We'll also share the slides, and as Rachel mentioned, we'll remove reference to those case studies, but we'll be sharing the recording and the slides with you all. And you'll also receive certificates within the next 4 weeks for this session from Northwest Melbourne PHN. But otherwise, I'd like to thank you all so much for being part of our session this evening, and have a pleasant evening. Thanks so much.
Thanks for the opportunity. Have a good night.
Bye.